This is EHRA Snacks, and I welcome Ken Nilsson and Oscar Cano. My name is Cosedis Nielsen. We're going to discuss two late breakers here. And let's start out, Dr. Nilsson, you published a paper on outcomes of leadless pacemaker implants compared to transvenous pacemakers in patients with sinus node dysfunction and no AV block. Let me start you asking, not long ago, we all left single lead atrial pacing for sinus node dysfunction based on a randomized trial because it had no benefit, more complications on the long term, AV block in 1.7% per year with need for upgrade, and more AFib with single lead atrial pacing. Why should we now reintroduce that?
Sure. So I think you're referring to the DanPace trial that I think you were actually involved with, and then an earlier paper published in Pace. But Christensen in 2001. And to your point, that those studies addressed in a transvenous system what the optimal pacing mode was. The fundamental system architecture has changed since then, because now we're able to approach patients with a modular approach that allows for progressive AV disease. And so the question's different now. The question is whether or not the lower complication rates that we're seeing with leadless pacing offsets the potential need for reintervention later on for that small subset of patients that go on to develop AV block, which is roughly 2%.
Thank you. You found less complications with the leadless.
Yes. What we did was we used two databases, one by Abbott, which was their patient data tracking for all of their leadless pacing, and then combined it with a Medicare fee-for-service database, which tracks complications going forward. So this is a database that is required for all new products and tracks all complications. But roughly we had 40,000 patients, about 400 patients that had Aveir ARs, 400 that had a right atrial only transvenous pacer, and about 40,000 that underwent dual chamber pacing for sinus node dysfunction. And just to summarize things quickly, the patients in the Aveir AR arm were typically sicker. They had higher Charleston comorbidity index, and yet their complications both at 30 days and at 1 year were roughly 50 to 60% less than the transvenous pacing arm.
Do you think that patient selection may have played a role also?
Yeah, I think patient selection definitely. This is a retrospective study, so there are certainly going to be biases on the part of the implanters. But again, the patients that were chosen for the Aveir AR were typically sicker, with longer hospitalizations, more likely to be admitted through the emergency department as opposed to electively.
Yeah. Do you think before widespread use of that we should do a randomized trial?
So I think the question is not whether or not leadless pacing is effective. It is, and the early safety data currently shows that it's very compelling. The long-term question is whether or not, for widespread adoption, whether or not a modular-based approach is superior to a transvenous approach, and if to drive that, a randomized clinical trial data would certainly be helpful.
Thank you very much, Dr. Cano. The left bundle CRT trial, you compared CSP, conduction system pacing, and biventricular pacing. And you did not find CSP or left bundle branch area pacing to be non-inferior to CRT, so potentially it could be worse. You obtained left bundle branch pacing in less than half the patients. Was that as expected?
Well, I think the first point is that from a strict statistical point of view, we did not reach the non-significant endpoint in the study. However, this can be explained by the fact that we reach a very high rate of CRT responders in the study. So this makes more difficult to reach the non-inferiority. And on the other hand, we had a very high rate of crossover. So this is obviously making more difficult to draw definitive conclusions. So that's the reason, because we conducted an on-treatment analysis where every patient was evaluated according to the final pacing modality received in the study. And in this on-treatment analysis, we found that conduction system pacing was actually non-inferior. And now, with respect to the capture pattern, we perform an exploratory analysis about the capture patterns in the left bundle branch pacing group. And this was independently evaluated by the steering committee. So, and we used very strict criteria for determining the left ventral branch capture. So only patients with true QRS transition during the incremental output pacing were considered to have left ventral branch capture. This rendered in 41% of patients having true left ventral branch capture, around 54% having a left ventricular septal capture. And we found that the CRT response rate in those patients with true left ventral branch capture was significantly higher, was 95% compared to the 83% in the left ventricular septal capture. So potentially this is the first time that a randomized trial is showing that direct capture of the conduction system make the difference when doing conduction system pacing for CRT.
And we have two other recent trials showing one is in one CSP superior and one it is inferior. And now you are, how should we do now in our practice? What do you think?
Well, I think our study, the left bundle CRT trial, just stands in the middle of these two previous studies. So on the one hand we have the Harsang LBBP study from China. So this was a very selected population, probably not comparable to our population here in Western Europe. 100% of these patients receive true left ventral branch capture. So I think that the results cannot be compared with our population. I think our study shows mostly a real life population where you need to decide which kind of pacing therapy are you going to deliver, and you are no longer patients allocated to biventricular pacing. You are no longer going to accept pacing thresholds that are suboptimal, or a very low threshold for phrenic nerve stimulation, or suboptimal coronary sinus branches. And that's the reason, because we had so many crossovers in our study. And on the other hand, the PhysioSync study, this was another completely different population, and the results were mainly limited by a high rate of deep septal pacing in that study. Almost 20% of patients had deep septal pacing, so this is not real left ventral branch arc pacing.
Dr. Nilsson, Dr. Cano, thank you very much, and thank you for listening to EHRA Snacks.
Thank you.
Thank you.
Thank you very much.
Thank you.